Hi everyone, this is Neil Writer, also known as the Wax Whisperer. Thank you for joining me in my latest video. I've decided to bring together 3 different cases for you in this video. And this is of case 1. This patient attended with bilateral occluding earwax. This is their left ear that I'm commencing with, and the earwax in this ear is a lot softer and mushier in comparison to their right ear. And that's because the patient advised that they used some earwax softening drops in their left ear prior to attending, whereas they didn't in their right ear. Quite often I actually prefer the wax being a bit dry and firm. It's a bit easier to remove. When it's soft and mushy and glutinous like this, quite often the suction probe, instead of suctioning the wax, it's almost just embedding into it, and it can block the inside of the suction probe. Hence why I've just put some medical grade olive oil spray in there, which helps to bind the wax together into a more of a homogeneous piece. In their right ear, because it's drier, I'm better able to get a suction grip, and I'm also able to use other instruments like an ear hook, forceps or curette. Here, an ear hook will just slice through this, it's just too soft. Similarly with forceps. A Jobson horn would help to possibly remove it, but the wax plug extends all the way to the eardrum, so inserting the Jobson horn that deep without making contact with the bony part of the ear canal and the eardrums, because we're going to have to get over and behind the wax. It's not firm enough where you can just leverage it into the core and slowly bring it forwards. So even that's more difficult with this consistency of wax. And this is coming away in 2 pieces. This is the first piece. The olive oil really has helped in this case. Also with a curette, sometimes what can happen, because the wax is soft, as you're bringing it forwards, you're almost smearing this wax and pushing it against the canal wall. It's almost like spreading butter on a piece of toast, which can then make it even more difficult to remove. So I'd much prefer removing it in big homogeneous pieces like that. That's the patient's eardrum. Slightly vascularized, a bit blood vessels are dilated posteriorly, but it's fine. It's just because the wax was right up against the eardrum. They have got kind of a bumpy ear canal. You may be able to see that when we visualize the inside of the ear canal. It's quite wavy at the base. So this is the right ear. It's drier, and as you can see, it comes away in one singular piece. Now, if it was really hard and dry, then it would be quite difficult to get a suction grip. But that consistency this is perfect. I'm just going to mop up around the edge. This is a bit of dead skin. We're on the cartilaginous portion, the outer third, so we can put a bit of pressure here. If this is on the inner 2/3 of the ear canal, the bony part, we've got to be really careful, because the bony part of the ear canal is really sensitive, and if we apply too much pressure, it would be uncomfortable for the patient. So I'm just going to the roof of the ear canal there, and just going to visualize the eardrum, which is nice and healthy. You can see the ear canal wall to the right is quite prominent, it bulges outwards, and we call that the isthmus, where the ear canal narrows and beyond that it widens out again, and it creates a hidden cavity anteriorly. We call that the anterior recess, and quite often you can get wax and dead skin stuck in the anterior recess. It's really hard to remove. This is patient 2. This is their left ear, and you can see immediately that this patient has been poking inside the ear with a cotton swab, or in the UK we call it a cotton bud. You can just see that indentation, and this is where this is the core of the indentation. This is the core of the crater that they've created. So again, just use some olive oil drops just to loosen this. It was quite stubborn, so use